Mentasy TV. Keep on watching Mentasy TV.
HMI. Other point about nutrition. Yeah, we could have a whole lecture just on nutrition for kids. But we want to avoid sugary drinks. We want a balanced diet, and then we want to follow the growth chart. All right, there's our dental caries. All right, so growth. I'm going to kind of skip over this kind of quickly. And growth is an important indicator of good health. There are some abnormalities of growth that you always want to be on the lookout for. You can see failure to thrive, so quarter weight gain, lots of different causes. Again, these could each be an hour topic in their own. Short stature, microcephaly, macrocephaly, obesity are some of the common things that we're looking for on our growth chart. Here is a picture of Miss Linda. Look at that baby. And then he started to gain and he started to slow down. Okay. So
you're fine. No, go ahead and do it. You're right on. Nope. Just touch your finger to here, but don't hit any. Now push that through. This left hand index finger over, cross over, bring the thumb through, and then you come back around. And it's hard. It doesn't make sense. I understand that. You have to cross over. If it's going to.
Okay, great. So, 2 hands. With one hand, I'm going to lift up your pinna. I'm going to lift up and back a little bit. Okay, that's just sort of opening up the space a little bit so I can get in here. So I'm going to lift up and back. I'm going to take it with my other hand. I'm going to gently insert the ear speculum into your ear and aim right down the canal. Oh, you have a beautiful ear. There's an elephant in there. We always like to joke with the little kids, I see a puppy dog, I see an elephant. Okay. So, lift up on the ear, you're going to gently insert the ear speculum and you're going to aim, and I'm aiming slightly front ways, maybe a little bit superior toward the very back of her nose, and I'm very gentle about it, okay? And then I'm going to switch sides, and I'm going to switch hands. So on this side, I'm going to use my hand in the back to lift up her ear, put the otoscope in my other hand, and I'm going to gently look in this ear. I'm scared.
I think you're putting more deep.
Miserable situation.
So your airway patency is maintained when you're awake, but when you fall asleep, your soft palate relaxes, and that's what snoring is the motion of that soft palate. So when you lie on your back and go to sleep, you snore. That the rest of your airway, except for your tongue and your soft palate, is all supported firmly, so it doesn't collapse. If you're a normal person, it doesn't collapse when you go to sleep, but otherwise it does. So when somebody falls down on the floor, their airway collapses, like when you're this guy. This is a nasopharyngeal airway. We also have an oropharyngeal airway. This is for people who are partially conscious. As you know, you can stick something up your nose and be okay. And that's what this does. We found that out with a COVID test, just how much that could happen and be okay. You should lubricate everything. Water works, or the jelly that the gel that you find in the OR or around the hospital, that works too. I think I'm good 10 times a minute. But usually what will happen is the first time you pick up the mask, your heart's going fast and you're breathing fast and you don't know what's going on and you start doing this. So in a minute or two, you'll say to yourself, okay, so that's not really necessary. I can just go 10 times a minute. Everybody calms down that's in the room. They were running around crazily, and now they've calmed down a little bit. And now everybody can think, okay, what did happen here? Why was this person laying on the floor when we came in the room? Let's think about this. So there always needs to be a leader in a crisis. You need to take charge. I mean, obviously, if somebody else has, don't fight about it. Just be an Indian. But so if you take this right here and Just gently, it's looking good. Okay, that's good. Maybe you have a little leak to your system. Okay, that's looking good. Maybe you could use a little head tilt, open the airway a little bit more. Ask your assistant, ask your assistant to do that. And then maybe you need to ask your assistant to put your hand right here and get better exposure right there. Okay. Patient, well, blue is looking pink. Thank you. It's time. Okay. All right. Take your seats, please.
Sure, ma'am.
We want to save our time and do direct laryngitis. And most people get attached to one or the other. But the way they work is this one, if this is your epiglottis, then this one reaches under it and lifts it up. So you can't see it. You look here into the larynx. And there's your vocal cords. You've found your spot. This one works differently. You put it in the vallecula up above the epiglottis, lift up, and the epiglottis lifts with it. And there is the opening that you're looking for. Lots of days when you don't have what you need, so you have to figure out how to get around that. One way is just to put the end of the tube right here and curve it, and then it kind of doesn't need a stylet in general. But your goal, the way that you do this is, it's very heavy, but you use it like a tool. You grab it like this, and this points this way on the patient. You grab it like it's some big power tool, but you use it very delicately because all of your mucosa is so tender, and if you do anything to it, it gets edematous and bleeds. And you think about it, if I'm offering you, I'm going to feed you, here, have a bite of this, and I have a fork, you're gonna back up first because you're like, okay, well, you're not sure that I'm not gonna damage your mucosa. This is you, with this, he can't even say anything about it, so be very gentle. There's something called cross finger technique. I don't think we've talked about this. Your fingers are, well, your whole body's easier to flex something than it is to extend. These are the strong muscles. This is the strong direction. Put your thumb on the mandible. Put your index finger on the maxilla and open their mouth. All right. As everything, it's better if the head's tilted a little bit back. And the tip of this, although generally you're aiming for this direction, perpendicular direction, put the tip over to the right because the tongue, it's just such a little beastie thing. It's always getting in your way. So you go put your blade to the right and push the tongue to the left. And you're not necessarily just looking down that hole, you're looking at the whole area. I don't know why they make it like that, but don't put the tube down in, and don't try to look solely down there. You want to get the whole view so you're looking sort of aside and sort of in it. Go to the right, lift, the tongue to the left, and you should not go in too far because if you're in very far, you're in the esophagus. Unfortunately, if you get into the esophagus in a real human being, when you lift up, it gives you this A-shaped look and you think you've seen the trachea, and you take your tube and put it in it. And then you're in the wrong place. So you just come out a little bit and look. Come out a little bit and look. And when you see anything else in his throat, that's his larynx because that's all else there is in his throat. Now, in a real human being, there's all sorts of tissue just sliding into your view. Watch that tip go down to that area. You're good. That's all the training we have time for, and he's sticky anyway. Once you get that tube where you want it, hold on to it, because the next thing that's gonna happen is you're gonna pull this out gently, also gently, because you don't wanna now break his teeth when you did this whole thing and didn't. Turn the light off. You're gonna need it for the next patient. You're gonna be so disappointed when you can't find any batteries. Don't let go of this tube until it is taped in place. Okay, if you had a stylet in it, you pull the stylet out and you blow up the cuff. Use a small syringe to blow up the cuff. Keep on pinching it here. Maybe you'll hold it yourself, or maybe you'll ask your assistant to blow up the cuff. But what you do is You put it in gently. This thing's in the trachea. You don't want to do something to damage it. Now, in this case, because it isn't actually, it is trachea, you get it blown up, it'll start coming back. It actually will come back to about the right pressure, which is actually 25 centimeters of water. Now, you might need to add a little air later. Don't know, might need to take a little air out. At any rate, then you hook up to your endotracheal tube. All these fittings are universal. If you have something in your hospital that doesn't work with all the fittings, get rid of it, because it'll just waste your time. All right, first breath is always gentle. You don't know if you're in, you don't know. Are you filling out the stomach? And you're like, oh, okay, that's not good. So you're not sure. Get your stethoscope. Listen here, listen here, listen over the stomach. You can hear it. If it's putting air in the stomach, you can hear it. And that's not good, because you created more risk of regurgitation of the contents of the stomach. If you think you're in, it seems like you're in, chest is moving, you're like, oh, okay, this is good. I think I did it. I think we're good. Then you can look at your pulse oximetry. I always look behind me because that's where my monitors are behind me. If it's not getting better, you start saying to yourself, I'm just wondering, is that in the esophagus? Because there's only two choices, pretty much. If things aren't getting better, you might not just rip the tube out. Might think, oh, I saw it go in. That's the number one thing, is watching it go between the vocal cords. But I saw it go in, but nothing's getting better. Let me take a look. You just put that blade in there, same way. Move on down till you find the right spot, and you say, well, I see it going between the vocal cords, so must be some other problem. As soon as you get the tube in, take a blood pressure. You could be crashing on the upside or crashing on the downside. Maybe, in a crisis, the patient was using epinephrine to keep their blood pressure up. Maybe they're hypovolemic. And when you put them to sleep, give them any sedation, all that goes away, and now their blood pressure systolic's 50. Or there wasn't enough anesthesia, or there is enough, but they're just hypertensive. Anyway, this is very stressful. So you can imagine somebody's trying to get you to swallow this, what your blood pressure would be. So that's the other way it can be a problem. Either one you want to treat. When you have a stylet in, the way you do it is you make what's called a J-turn in the end. This is the silhouette that you want it to have before you use it. If you just can't make this work, then take it out. Don't keep doing what doesn't work. Just like, well, leave on their own. And we're not opening a major body cavity, so this works fine. We give them gas through this, works fine. But if you have a large surgery, or you have a full stomach, or you're opening a body cavity, then you definitely need to intubate. Or they're going to the ICU. You already know that. You're going to need an endotracheal tube. Okay, suppose you do all that and you can't get the tube in, and now you've made the airway pretty bad, and you can't mask them anymore, and everything's just terrible, and the patient's blue. What are you going to do next? What? All right, yes. Cricothyrotomy is what you do. It's the best thing to do in that crisis situation. And one of the best ways in the hospital to do it is just grab your central line kit. You'll already know how to do this. It's the same exact motion, but you're looking for air instead of looking for blood. So you grab the kit, you tell somebody, put some betadine on the neck. I've got to do cricothyrotomy. It's going to be messy. You know that. You've just got to steel your mind. It's not something you want to do. It's not something you ever want to do. But you grab this. You can use this hollow bore needle, or you can use this catheter, either one. All right, so on your own neck, find your hyoid bone. All right, now below that's the thyroid cartilage. Your vocal cords are kind of in the middle of that thyroid cartilage. So you want to be below that. or you haven't done yourself any good to make a hole higher than that. All right, find your Adam's apple. Almost every person, no matter how much they weigh, you can find that spot. Come straight down, and the first little hole you fall in, that's your cricothyroid membrane. That's the easiest way to get into the trachea. The cricoid is the thyroid cartilage sits like this, and the cricoid is below it. It's fat in the back, skinny in the front. The thyroid kind of rides on top of it like this, and there's a little hole right in the front. That's what you're looking for. So you stick that in there, get that air. You have a syringe on here because you're searching for air. Stick it in when you find that spot. Stick it in until you get air. When you get air, you're like, oh, that's good. Stop. And take this off. You have this nice wire in this kit. And you want to put the curved in. It has a straight in and a curved in. You want to put the curved in down this needle because you want it to curve and go down into the trachea. Once you get the wire in, you take this holding apparatus off, and you got the wire sticking out of the neck. This, you take off the wire, and you get your scalpel right here and make a hole. That's your hole you're going to put an endotracheal tube. Get a little pediatric tube, get a tube. And once you make your hole, and I mean go in there and make a hole. Don't make a little hole and then you try to get the tube, you can't come back out, make another hole. All that time this patient is getting no oxygen. So make a hole. Now there's going to be blood everywhere, it's a mess. Just keep on going. All right, you've made your hole, somebody get me a little tube. You run the tube down that wire, and it's going to be hard to get it in. You get it in, pull out the wire, and your little tube is going to hook up to this. And you're going to gently give a little breath. I know it's a really exciting time, but you're going to give a little breath. Okay, I think that's working okay. You're always going to keep on gently doing this till you can get somebody to come help in some way. Get an ENT surgeon, do a trach, find somebody that actually can intubate, whatever it is you move on to next. If you don't have anything, say, get me a scalpel. Get me a number 11 blade, stab it into that area, stick something in the hole. Something. Put it in the hole. You don't want to lose that hole. And then get a pediatric endotracheal tube, push it down the hole, and take this out, and you can do anything. Okay. How many minutes do we have left? 20 minutes? Okay, I want to tell you one thing, and that is for the patient's family. So people don't think about death, they don't plan for death, and they don't want you talking about death. You want to ruin your time at a party, say to somebody, oh, so what are you thinking about your impending death? They will not talk to you very long, right? So people come totally unprepared. Here's their uncle at the hospital. You go to the family, you say, he isn't doing very well. I'm sure you know, it's a serious problem. And I don't know that he's going to survive. We do have a condition that if you came to talk to him, he might hear you. Sometimes if you could avoid intubating him, maybe even he's in a state that he could talk a little bit. It's just something you have to use your own judgment about. But say you've intubated him, it's like, it's possible he could hear you. I can't tell you he couldn't. But I think it would be good if y'all want to go and talk to him and say whatever you want to say to him. And something you can suggest to them is, there's 6 things you could say to him. I'm sorry. I forgive you. Thank you. I love you. It's okay to die. Goodbye. Get choked up blood. They have their own specifics of that. Each of those things, you know what you would say. So it is important to teach that. And it's almost always a bad time. Now, if you're a family practice, you might have some time to teach this to patients or to their families. But in this situation, you're not going to have much time, but frequently it needs to be taught. And you, as he was telling us today, you're a teacher. I know we didn't choose to be teachers, we didn't think of it like that maybe, but that's what we ended up being. Okay, so now I want you to practice.
Perfecto.
You know, I've heard people say it's not true.
Yes. Yeah. So now can you open this one?
Like the empty
Happening, but probably it
because
could.
like I saw it on medical shows, but I don't know
Okay.
if it's
You
practical.
know, I'm sure that's played up because
Yeah.
most of the time when you encounter somebody, you're going to have something,
Exactly.
right?
Yeah.
And if you don't, you should be masking the patient and calling EMS or something, right?
Yeah,
Yes,
yeah.
if it's in your office,
Yeah.
you call 911, whatever you do.